Imagine you're sitting in a doctor's office. You are in blinding, just relentless agony.
Oh, yeah. The kind where you can barely think.
Exactly. Like the pain radiating down your back is destroying your ability to work, to sleep, to just, exist as a human being. And the doctor slides an MRI across the desk.
And it looks perfect.
It is perfectly, beautifully normal. They look you right in the eye and say they can't find anything wrong. But the data we are unpacking today proves that staring at that quote-unquote perfect MRI might actually be the exact thing making your physical pain significantly worse.
It sounds totally backwards, I know. But the human brain is this incredible prediction machine, right? And when you feed it a really confusing narrative like, hey, you are in absolute agony, but there is zero structural damage, it doesn't just calm down.
No, it panics.
Exactly. It panics. It actually amplifies the danger signals.
Huh.
So getting an MRI or an X-ray for chronic pain can, in many documented cases, cause severe spikes in anxiety, prolonged disability, and honestly, objectively worse pain than if the patient had just never seen the scan at all.
Which is wild.
Okay.
So we are diving straight into the deep end today. Whether you're currently navigating this medical labyrinth for yourself, or maybe you're advocating for a loved one, or you're just fascinated by the absolute frontiers of human biology, you've probably bumped into this massive systemic misunderstanding of how the human body processes long-term suffering.
Yeah, it's everywhere.
It really is. And our stack of sources today is just mountainous. We are pulling from umbrella reviews on mental health and pain that aggregate data from over 17 million people.
17 million?
Yeah, that's not a small sample size. And we also have the latest clinical guidelines for opioid prescribing. We've got cognitive behavioral therapy manuals specifically engineered for chronic pain, and some really specialized patient handbooks from the UK and Sweden.
And synthesizing all of this data, it points us toward one monumental mission for today's deep dive, which is mapping out the profound psychological and, well, practical shift required to survive the modern healthcare system.
Right, because it is about survival.
It really is. We are talking about the transition from being a passive patient, someone sitting there in a paper gown just waiting for a doctor to dispense a magical cure, to becoming a fierce medical advocate.
Someone who operates as the chief executive officer of their own complex biology. I love that framing, moving from the passenger seat to the driver's seat.
Precisely.
But to even get the keys to the car, we have to dismantle a pervasive myth that our sources call the fix-me fallacy.
Yeah.
And that really starts with drawing a harsh biological line in the sand between acute pain and chronic pain, because we use the same four-letter word for both, which is arguably a massive linguistic failure.
It's a huge failure. They are fundamentally entirely different biological events. Honestly, they're completely different diseases.
So break that down for us. Let's start with acute pain.
Okay, let's look at the evolutionary biology of acute pain. When you touch a hot stove or, say, you severely sprain your ankle, your body releases this, they call it an inflammatory soup of chemicals. Right. Very appetizing. Things like prostaglandins and bradykinin. And this triggers an unpleasant, highly dynamic psychophysiological process. But, and this is key, it has immense survival value.
Excellent.
Yes, it's a brilliant evolutionary warning system. It forces you to limp, to guard the injured tissue, and to rest so the cells can physically rebuild.
So the body is basically screaming, stop using this ankle so I can patch the drywall.
Exactly. That's acute pain. Chronic pain, however, is generally defined by clinical guidelines as pain persisting beyond the expected tissue healing period.
Which is usually, what, around 3 months?
Usually crossing the 3-month mark, yeah?
Yeah.
And at this stage, the original tissue damage has often completely healed. The drywall is patched, but the alarm is still blaring.
That sounds exhausting.
It is. And the medical literature now explicitly states that chronic pain contains little to no evolutionary benefit. It is no longer a symptom of an injury. The alarm system itself has become the disease.
Which pulls us directly into what the literature calls the triage trap. And I found this fascinating. This is the systemic limitation where modern medicine takes the acute care model, which is brilliant for a broken leg or a bacterial infection, and incorrectly applies it to chronic conditions.
Right, because in acute care, the solution is passive.
You rest, you take an antibiotic, you just let the body heal.
But applying that passive acute model to chronic pain is where the medical system actively harms patients. There's a prominent researcher named Vlaien who wrote extensively on this. He calls it the paradox of rest.
The paradox of rest.
Yeah. If you rest to cure acute pain, you heal. But if you rest to cure chronic pain, you initiate this devastating cascade. You lose cardiovascular endurance, your muscles atrophy and become stiff, you lose joint mobility.
And then that physical decline leads to severe fatigue, right?
Exactly. You stop going out, your social world shrinks, you become isolated. The very behavioral instinct that evolution gave you to save your life is now accelerating your physical and psychological decline.
Okay, wait. I need to push back on this a little bit because the line between irrational fear and just basic self-preservation feels very blurry here to me.
Fair point.
You're telling me rest is bad, but if I have, say, a bulging disc in my back and my pain is an 8 out of 10 today, and I go deadlift 200 pounds or run a 5K just to, stay active and not rest, I'm going to end up in the emergency room. How are we distinguishing between counterproductive resting and just basic common sense?
That is the critical distinction, and it comes down to understanding pacing versus pushing.
Mm-hmm.
The literature absolutely does not advocate for recklessly loading a vulnerable joint.
Okay, good.
Right. If you deadlift 200 pounds during a flare-up, you are introducing acute mechanical stress, which causes new acute pain. The trap isn't taking a day off when you have a flare-up.
Yeah.
The trap is adopting a lifestyle of total immobility while waiting for a passive medical intervention to, quote-unquote, fix you before you resume living.
The fix me fallacy. I saw this explicitly addressed in the cognitive behavioral therapy manuals for the VA. It is this trap of putting your life entirely on hold, waiting for a single passive modality, like a specific surgery, a new nerve block injection, or some breakthrough pill, just hoping it'll turn the clock back to before the pain started.
Yes, and therapists are actually warned to watch out for patients who put all their eggs in this one surgical basket.
Because the long-term outcome of that singular reliance is almost universally disappointing. And the systemic, socioeconomic toll of this fallacy is almost difficult to comprehend.
It's staggering.
In the United States alone, the annual cost of chronic pain, and this is factoring in direct medical costs, lost productivity, disability programs, it's estimated between $560 and $635 billion.
Billion. With a B.
Yeah. And looking at Sweden, which is a much smaller population, an analysis found it cost 87.5 billion Swedish krona in a single year. And indirect costs, like long-term sick leave, accounted for the vast majority of that number. We are hemorrhaging billions of dollars globally because we're treating a complex systemic disease with a broken arm mentality.
And the reason the broken arm mentality fails is that, as we established earlier, the physical break isn't even there anymore.
Right. If the drywall is patched, why is the fire alarm still going off? This disconnect between the physical tissue and the pain experience is what the sources call the clinical gap.
This is where it gets really interesting.
Let's get back to that perfectly normal MRI we talked about at the start. How can someone be in paralyzing pain if the scans are entirely clean?
So the clinical gap is this massive, incredibly frustrating void between what objective medical imaging can detect and the patient's lived biological reality. And to understand this, we have to discard this pervasive myth that if a doctor can't see it on a scan, it must be a psychological manifestation.
Right, like you're just making it up.
Exactly. Patient handbooks, like the ones from First Psychology in the UK, they print this in bold letters for a reason. All pain is real. There is no such thing as imaginary pain.
That is so validating to hear.
It needs to be said. Furthermore, all pain, whether you sever a finger or have fibromyalgia, is generated in the brain.
Because the brain is the control center interpreting the body's electrical signals.
Exactly.
So to explain why a scan shows nothing while the patient suffers, the clinical updates by researchers like Cohen break pain down into 3 distinct categories. Let's look at the biology of each, because this really clicked for me.
Okay, so category 1 is nociceptive pain. This is the hot stove we talked about. Actual tissue damage. Receptors in the skin or organs send a danger signal up the spinal cord to the brain.
Makes total sense.
Right. Category 2 is neuropathic pain. This is an injury or disease of the nervous system itself.
So like a frayed electrical wire.
Perfect analogy. Like a severed nerve from an amputation or diabetic neuropathy, where high blood sugar actually damages the peripheral nerves. Both nociceptive and neuropathic pain often have clear, observable physical causes that a scan or a nerve conduction study can identify.
But the third category is the ghost in the machine. Nosoplastic pain.
Nosoplastic pain. This is where the clinical gap exists. The pain arises from a completely sensitized central nervous system.
Let's sensitize how?
It's driven by neuroplasticity, the brain and spinal cord's ability to reorganize their neural pathways. When you are exposed to prolonged pain, your nervous system actually changes its physical structure.
Wait, it physically changes?
Yes. The synapses that transmit pain signals become more efficient. Neurotransmitters like glutamate and substance P just flood the spinal cord, and glial cells, which usually just support neurons, they start releasing inflammatory chemicals that lower the firing threshold of your pain receptor.
It's like a car alarm with a break-in hypersensitive sensor. Like a properly functioning car alarm nociceptive pain goes off when someone smashes the window with a crowbar.
Yeah.
Right. The threat is real.
But nosoplastic pain is when the internal wiring of the alarm system gets so sensitized that the alarm starts blaring at 3 in the morning just because the temperature dropped, or a leaf blew past the tire.
That's a great way to look at it.
The noise of the alarm is identical. It is just as loud, just as disruptive, but the physical car is completely intact.
And that biological reality is exactly why the perfectly normal MRI can be so dangerous.
Explain that.
Yeah.
How does a picture cause danger?
Let's say you have this highly sensitized nosoplastic nervous system. Your sympathetic nervous system, the fight or flight response, is just locked in the on position. You go to a doctor and they show you an x-ray. Now, most adults over 30 have some normal age-related disc degeneration.
Right, it's just the internal equivalent of getting wrinkles.
Exactly. But your hypervigilant brain looks at that scan, sees a slightly compressed disc, and the amygdala, the fear center of the brain, screams, "Aha! Look at that severe damage. We're in terrible danger."
Oh, wow. So the visual proof of the pain acts as a nocebo effect.
Yes. The fear and hypervigilance actually increase the sympathetic tone, which floods the body with cortisol, which then further lowers the threshold for pain signals.
So the scan literally pours gasoline on the nosoplastic fire.
Precisely. If we understand that the brain is actively amplifying these signals through neuroplasticity, we have to look at what that prolonged state of high alert does to the brain's overall chemistry.
Because you cannot leave the brain's emergency alarm blaring for years without it deeply, fundamentally altering the mind.
You really can't. And this leads us to the staggering data from the Stubbs Umbrella Review regarding mental health.
The Stubbs et al. Review from 2025. And just for context, when we say umbrella review, we aren't just talking about a single clinical trial here. An umbrella review aggregates systematic reviews, which themselves aggregate individual studies.
To the highest level of evidence.
Yeah, they are looking at massive forest plots and confidence intervals across 957,000 patients with mental health disorders, compared against 16.6 million control subjects.
The statistical power here is practically irrefutable.
It really strips away any remaining skepticism about the mind-body connection, doesn't it?
Completely. I mean, in the general population, chronic pain sits at a prevalence of roughly 20 to 25%. But the Stubbs review found that in patients with post-traumatic stress disorder, PTSD, up to 96% experience chronic pain.
96%. That is almost everyone.
Almost everyone. For patients with major depressive disorder, it's 53 to 65%. For adults with ADHD, it's nearly 67%.
96% of PTSD patients. I mean, that is not a coincidence. That is a biological mechanism at work.
It is the HPA axis, the hypothalamic pituitary adrenal axis, locked in overdrive. PTSD is a disorder of profound nervous system dysregulation caused by trauma. The body perceives a constant existential threat.
So it never turns off.
Never. Because the sympathetic nervous system never powers down, the parasympathetic nervous system, the rest and digest network responsible for cellular repair and lowering inflammation, it rarely gets to engage. The body is saturated in stress hormones, which, as we discussed with nosoplastic pain, actively sensitizes the neural pathways to interpret normal physical sensations as agony.
And the data shows this streak goes both ways, too. Having multi-site chronic pain increases your risk of developing depression by 88%. Meanwhile, having depression increases your risk of developing chronic pain by 26%.
It's an inescapable feedback loop. But the real tragedy of this deep biological connection is how the medical system misinterprets it.
Yeah, the sources warn heavily about a phenomenon called diagnostic overshadowing.
Oh, this makes me so angry.
It's infuriating. This occurs when a patient with a documented psychiatric condition, like depression or anxiety, presents to a clinic with severe physical pain. Instead of treating the sensitized nervous system, the physician attributes the physical pain entirely to the mental illness.
They just dismiss it as psychosomatic.
Right. The doctor essentially says, your back is fine, you're
Yeah.
just depressed.
Which completely alienates the patient.
Absolutely. Because if I'm the patient and I'm hearing that my pain is intimately linked to my depression, it sounds exactly like the doctor is blaming me for my own suffering. It sounds like, well, if you would just smile more and stop worrying, your spinal pain would vanish.
Right, which is absurd.
So how do we separate the hard biological reality of this mind-body connection from the toxic stigma of it's all in your head?
We look at the neurochemistry, specifically how treating the brain's processing centers directly alters the physical sensation of pain. The sources highlight this truly fascinating study by Isakli and colleagues looking at the intersection of ADHD, autism, and chronic pain.
I read this part. This blew my mind.
When patients with ADHD were treated with central nervous system stimulants medications specifically designed to increase dopamine and norepinephrine levels in the brain to improve cognitive focus, their prevalence of chronic widespread pain plummeted from 42% down to 16.7%.
That is incredible.
Right?
Why does a focused drug cure body pain?
It comes down to the brain's descending pain modulation system. Dopamine isn't just about reward and focus. It plays a critical role in the neural pathways that travel from the brain down the spinal cord to actually inhibit incoming pain signals.
Wow.
Yeah. ADHD often involves a dysregulation of these exact dopamine pathways. So, by correcting the neurochemical deficit for the mental health disorder, the stimulant effectively rebooted the brain's ability to filter out and suppress those nociplastic pain signals.
So the mind-body connection isn't a metaphor. It is plumbing and electricity.
It is literal hardware.
So the biology is undeniable, but the medical system is still trapped in this diagnostic overshadowing. If doctors are dismissing the pain or misunderstanding the neurochemistry, the patient is left in an incredibly vulnerable position.
Extremely vulnerable.
Which means the patient has a choice, right? You can keep begging an authority figure for validation, or you fundamentally change the dynamic. We have to talk about breaking authority bias.
Authority bias is perhaps the most difficult psychological hurdle in modern medicine. From childhood, we are conditioned to view doctors as omnipotent figures. You enter their domain, you put on the paper gown, you sit on the crinkly paper, and you adopt a completely subservient role.
You present your broken parts, and you wait for the authority figure to dispense the fix.
Exactly.
But if we know the fix-me fallacy is a trap, then sitting on the exam table waiting for the boss to give you a cure is a guaranteed path to lifelong disability. The paradigm shift the sources advocate for is treating the doctor not as your boss, but as a specialized consultant. You, the patient, are the chief executive officer of your biology.
I think the CEO and consultant analogy is the perfect lens for this. Think about it. If a company is failing, the CEO might hire an outside analytics consultant. The consultant comes in, runs the numbers, and hands the CEO a data report.
Which in our case is the MRI, the blood work, or the pharmacological options.
Right. But the consultant doesn't run the company. The CEO has to take that data and decide how to execute a pivot based on the daily operations on the factory floor.
Yeah.
The doctor provides medical expertise, but you are the foremost world expert on your own lived experience.
And frankly, you have to be the CEO because the consultants are operating in a deeply flawed industry.
Very flawed.
The sources, particularly Dr. Myra Glashan's work, they outline the brutal systemic realities of pain management. Primary care physicians are often forced into 15-minute consult windows. They just do not have the time to unpack complex nociplastic neurobiology.
No, they don't. So they feel immense pressure to quickly prescribe opioids just to get the patient some relief and, move to the next room.
But simultaneously, they are terrified of DEA regulatory scrutiny for prescribing those very same opioids.
It's an impossible situation for them, too. And many physicians openly admit they lack comprehensive training in multidisciplinary pain management. But the failure of the system goes much deeper than time constraints. The clinical guidelines shine a stark light on severe demographic disparities in pain management.
Yeah, this isn't just a matter of bedside manner. It is a documented medical reality that vulnerable populations receive fundamentally different and often inferior care.
Let's look at that data.
The guidelines show that Black patients, women, Native Americans, who actually report the highest overall prevalence of chronic pain, by the way, and members of the LGBTQIA2S plus community frequently have their pain underestimated by providers.
And we have to understand why this happens medically. It is a toxic mix of a lack of representation in clinical trials and deeply ingrained, historically false biological myths.
Like what?
Well, for decades, medical education harbored horrific, baseless myths about differing biological pain tolerances among different races, or they dismissed women's pain as just hormonal hyperreactivity.
Just shocking stuff.
Right. Because of this structural bias, these groups are consistently prescribed less analgesia for the exact same observable injuries as white male counterparts. They are more likely to be offered solely pharmacological solutions, often with heavy suspicion, rather than comprehensive, multidisciplinary physical therapy and psychological support.
So for these patients, adopting the CEO mindset isn't just a neat self-help trick. It is an absolute requirement for biological survival.
You have to self-advocate.
You cannot outsource the management of your nervous system to an institution that historically and currently undervalues your pain. I mean, a surgeon or a chiropractor is not going to be sitting next to you at 2 a.m. on a Tuesday when a massive flare-up hits and you can't breathe through the pain. You are the only one on shift.
That is the ultimate truth of chronic illness. You have to be the project manager of your own symptom toolbox. The clinical literature pushes for shared decision-making, describing the ideal clinical encounter as a co-researching journey.
The CEO takes the consultant's advice, but the CEO steers the ship. Which brings us to the operational floor. If you are the CEO, what are your daily tasks? How do you actually manage this deeply complex nasoplastic alarm system when it's just screaming at you? This is the realm of tactical advocacy.
Yes. The very first executive decision the CEO must make is redefining the objective of the company. You must officially abandon the search for a cure.
I know that sounds incredibly bleak at first.
It does, but it is actually the key to liberation. The new objective is optimizing your functional baseline.
And the mechanism for optimizing that baseline relies heavily on SMART goals. Now, the CBTCP manual, the Cognitive Behavioral Therapy for Chronic Pain Protocol, treats SMART goals as the absolute foundation of recovery. To understand why, we can't just define the acronym. We have to look at how achieving these goals physically alters the nervous system.
Right. So SMART stands for specific, measurable, achievable, relevant, and time-bound. Let's look at the neurobiology of why vague goals fail. If a patient says, I want to get my old life back or I want to get in shape, the brain cannot process the steps required. When the patient inevitably fails to instantly achieve that massive, vague goal, the brain experiences a negative reward prediction error.
A negative reward prediction error, what does that do?
It triggers frustration, stress, and a spike in cortisol, which, as we know, amplifies nasoplastic pain.
Oh, wow. But a SMART goal changes the neurochemistry. If the goal is, I want to be more active by walking to the end of my driveway and back twice a week for the next 2 weeks. That is specific. It is measurable.
And achievable.
Right. When you complete that walk, your brain registers a successful task completion. You get a microdose of dopamine. And as we learned from the ADHD data, dopamine actively engages the descending pain modulation pathways, physically dampening the pain signals.
You are literally using behavior to drug your own nervous system.
Love that.
But a CEO also needs metrics. You can't manage what you don't measure. Patients are taught to rigorously track data using tools like the PEG scale.
The PEG scale, that measures 3 things, right?
Yeah. Right.
Pain intensity, interference with enjoyment of life, and interference with general activity.
The CBTCP manual features a brilliant case study about a patient named Juan that perfectly illustrates this data-driven approach. Juan came into the clinic heavily reliant on high-dose opioid medications.
Like a lot of people do.
Yeah, and the therapist sat down and held up the mirror, basically showing Juan the data. These medications haven't cured your pain, but the side effects have successfully isolated you from your friends, your family, and your life.
Juan's pivot is a masterclass in the CEO mindset. He stopped waiting for a better pill. He looked at his functional baseline and implemented specific data-driven interventions.
What did he do?
For his desk job, he started using a 10NS unit, a transcutaneous electrical nerve stimulation device that uses mild electrical currents to disrupt pain signals locally. He utilized pacing at work, setting a hard rule to stand up, stretch, and walk for 2 minutes every single hour, preventing the muscle stiffness that triggered his flare-ups. But the most important thing Juan did was tackle the isolation. He recognized that his shrinking social life was causing depressive symptoms, which we know fuels the nasoplastic fire. So he set a SMART goal to meet his friends for coffee once a week. And the crucial detail in the manual is that Juan committed to going regardless of his pain levels that day.
That decision strikes at the very heart of 2 massive psychological concepts in pain management.
Which are?
self-efficacy and fear avoidance beliefs. Self-efficacy is the deep, internal, hard-won belief that you can execute a behavior and achieve a goal despite severe obstacles. Every time Juan paced his workday successfully or drank coffee with his friends while in pain, his self-efficacy grew. He proved to his own brain that the pain was not lethal.
And that directly combats fear avoidance beliefs, or FABs. Fear avoidance is the paralysis that happens when you are so terrified that any movement will cause catastrophic structural damage that you become entirely sedentary. The literature demands that patients learn the profound difference between hurt and harm.
Distinguishing hurt from harm is the hardest mental leap. Hurt is an unpleasant sensory experience. Harm is actual physical tissue damage.
So because of the sensitized alarm system, a person with chronic nosoplastic pain might feel agonizing hurt when they walk down the driveway.
The car alarm is deafening.
Right, but they're not actually causing harm to the tissues of their spine or their knee. Overcoming fear avoidance requires graded exposure, slowly, methodically, teaching the amygdala that movement is safe, even if it is uncomfortable.
It takes so much courage.
It really does. But let me ask the question that every listener dealing with a chronic condition is screaming at us right now. You do all this. You set the SMART goals. You track your PEG scores. You distinguish hurt from harm. And then a massive flare-up hits out of nowhere.
It happens.
It drops you to the floor. You can't walk to the driveway. You can't sit at your desk. You feel like a total failure back at square one. Doesn't this entire CEO framework just collapse under the weight of a severe flare-up?
The despair in those moments is crushing. It is the darkest part of the chronic pain experience. But a flare-up does not mean the framework collapsed. It means the framework is being tested.
Tested how?
Well, in the old passive patient model, a flare-up is a catastrophic failure. It means the intervention didn't work and the doctor failed you. In the CEO model, flare-ups are accepted as a statistical certainty. They are the rule, not the exception.
So a good CEO doesn't just draft business plans for when the economy is booming. They have a crisis management protocol for the recession.
Exactly. You anticipate the flare-up. You build a written protocol when you're feeling relatively okay. Maybe your flare-up protocol involves a specific diaphragmatic breathing exercise to manually lower the sympathetic nervous system tone, a pre-planned reduction to basic survival tasks, and a specific short-term medication adjustment you've already cleared with your consultant.
So when the flare-up hits and your brain is panicking, you don't have to improvise. You just execute the protocol.
Yes. And we have hard, empirical evidence showing that this active, managed approach dramatically outperforms the passive search for a cure. When researchers study active psychological interventions, things like mindfulness-based stress reduction and CBT for chronic pain, the data reveals a fascinating nuance.
I love this part.
These interventions often have only a small to moderate effect on actual pain severity. The raw volume of the pain might only drop by 1 or 2 points on a 10-point scale.
But the effect on pain interference and disability is massive and statistically highly significant.
Huge.
The pain might still be a 6 out of 10, but the patient is no longer lying in a dark room waiting for it to be a 0. They're at their daughter's soccer game. They are modifying their work environment. They're actively engaged in their own life. The pain is present, but it is no longer the dictator.
By taking control of the data, pacing your biology, and relentlessly focusing on your functional baseline, you fundamentally rewire your identity. You transition from a victim of a broken medical system to an agent of your own life.
It is incredible. Let's look at the territory we've mapped out today. We started by rejecting the triage trap, the dangerous misconception that resting will cure a chronic sensitized nervous system. We dismantled the fix-me fallacy, acknowledging that putting our lives on hold for a single passive cure costs billions of dollars and steals years of our lives.
And we explored the deeply misunderstood clinical gap, proving that all pain is real. We delved into the neuroplasticity of nosoplastic pain, where the brain's alarm system acts like a car alarm with a hypersensitive sensor.
We examined the monumental data from 17 million people, proving that physical pain and mental health disorders like depression and PTSD are biologically intertwined through the nervous system and dopamine pathways.
We confronted the systemic disparities that force marginalized patients to advocate for themselves.
And finally, we outlined the tactical shift. Firing the doctor as your boss, hiring them as your consultant, and using SMART goals and PEG tracking to slowly, methodically reclaim your life.
It is a massive, exhausting paradigm shift. It requires grieving the loss of the clean, broken arm narrative. It requires mourning the definitive cure. But it is also the most deeply empowering realization a patient can have.
And if we step back and look at this journey through a broader philosophical lens, it reveals something truly remarkable about human adaptation. Think about the skill set required to survive this process. You have to learn to set rigid, unapologetic boundaries with your time and energy.
Yeah.
You have to manage profound fear and anxiety on a daily, sometimes hourly basis.
Mm.
You are forced to look at deeply flawed, terrifying data coming from your own nervous system and interpret it rationally rather than emotionally. You have to aggressively, deliberately seek out moments of joy and connection despite the constant heavy presence of suffering.
You are forging a psychological exoskeleton.
You truly are. What if the grueling, unglamorous process of becoming a fierce medical advocate for your chronic condition actually makes you infinitely more equipped to handle every other unpredictable crisis life throws at you?
The resilience required to manage nociplastic pain translates to every boardroom, every relationship, and every tragedy. You aren't just learning to manage a bad back or neuropathy or a systemic autoimmune issue. You are taking an advanced, involuntary masterclass in the human condition.
When you step into the diagnostic muddy waters of chronic pain, you don't get the comfort of a clean x-ray. You don't get the simple, binary narrative of a broken arm. But if you take the data into your own hands, if you refuse to wait for a rescue ship that isn't coming, you might just find that navigating the darkest storms makes you the most capable pilot on the water. Keep tracking your data, keep pushing your functional baseline, and we will catch you on the next deep dive.